Welcome to the Ortho on the Go podcast. My name is Chuck Dowell, host of the podcast. This is an educational orthopedic podcast focused on discussing both clinical and functional orthopedics. We will discuss a variety of topics within the field of orthopedics, including reviewing interesting cases, hearing from different professionals throughout the orthopedic profession, and discussing common musculoskeletal injuries and complaints. This podcast is meant for anyone that wants a better understanding of orthopedics, including all levels of practitioners, coaches, parents, and athletes themselves. Hello, everybody, and welcome back to the podcast. Thank you again for joining me. I think today is an interesting episode. So we're at that time of year where my clinic, as well as a lot of your clinics, are participating in pre-participation sports physicals. And every year I kind of ask myself, why do we do these things? What are we screening for? Kind of what are we looking for? Just the other day, me and two other providers did physicals at a local high school and had over 300 athletes, come through to do these pre-participation physicals. And I think it's always important to update ourselves as to why we do these physicals, what we're looking for on these physicals, what are the, indicators for they should get further evaluation. So, when we talk about sports physicals, the main reason we do them is to evaluate to see for any life-threatening conditions. And one of the most commonly documented ones is that sudden cardiac death from cardiomyopathy. And, there's a lot of research that's gone into can pre-participation physicals, screen for this? Can they help prevent this? There's a long running study out of Italy that showed they did pre-participation EKGs and all of their athletes. And it took quite a while to show that was a cost-effective thing to do to evaluate for screening of sudden cardiac deaths or risk factors for sudden cardiac deaths. We also do this to detect any conditions that may predispose the athlete to injury. So maybe they have some evidence of hypermobility, maybe they have some scoliosis, they have a prior injury or some kind of prior joint instability that could lead to injury as well. Some of these athletes are coming off of injury, and so you can do the medical aspect of the physical, but not necessarily clear them for that orthopedic aspect of the physical. So what are the realistic expectations? What can we do and what can we not do? So I think realistically, we can identify conditions warranting further evaluation. So if they complain of exertional, chest pain or some type of difficulty breathing, they have an underlying history of family cardiac problems at a young age. These are things that we can screen for and then send them for further evaluations with a cardiologist or pediatrician, whoever it may be. Most of the physical, and I think the most important part of the physical, and I try to preach this as well in general, is the history portion. We all have those screening questions as part of our physical, and I don't see an athlete unless they fill those questions out. A lot of these athletes kind of just draw a line through that no column and fill the questions out, but there are some specific questions that I like to ask that I think help with the screening process to ensure that I'm not missing anything, despite they're just kind of filling out the no's in those questions. Open conversation regarding mental health and safety. A lot of our physicals, our pre-participation physicals now have questions regarding this. Do you have any depression? Do you have a history of anxiety? Do you have concerns at home? Do you have any, weight concern issues? And sometimes the athletes are not safe or don't feel safe filling these out in front of their parents. And so some of these questions have to be asked in a delicate fashion for sure. You may ask the parent to leave the room briefly to ask some of these questions if it is necessary. We can document any baseline for future injury comparison. So, if somebody comes in and has, some type of joint laxity or pain and has an injury in the future, we can look back at that and say, hey, when we did that pre-participation physical, did we notice that as well? And then we can create records, for the school and team, and our specific clinic scans all of these physicals in, so we have a record copy of them. So if they do have to come back for any type of injury, we can, have a scanned document. What are the limitations? We cannot exclude all causes of sudden cardiac death. There's a lot of literature that shows that these physicals cannot completely rule out, especially if we're not performing an EKG on these athletes or patients. There's a low prevalence of disease yields. There's a lot of false positives, when we ask, the athletes questions. Athlete may report the history, as incomplete or inaccurate. So again, a lot of them just want that physical to go by as quickly as possible. So we'll just draw kind of a line through those no questions. And so we'll go through this, but I think there are some specific questions on that history that we should ask every time, even if they've answered no, just to make sure. Because occasionally I will catch, an athlete that said no, but actually has some kind of history. Does not substitute for their primary care visits. We should not have the athlete use this as their primary care, pre-school physical. They should still get their yearly physicals and the lab works and all that stuff with their pediatrician or primary care, as they know their history and they know their family history and have that established relationship with them. And then again, it doesn't replace any sports-specific injury prevention programs. So, we do a lot of injury prevention programs, single leg landing techniques for soccer and basketball athletes, and this physical doesn't necessarily prevent that. And then you can see there at the bottom, fewer than 2% of athletes are also ultimately restricted from the sports participation with these physicals. Timing, ideally, we want to do this 6 weeks before the season, fall season starting up. So our clinic is inundated with, physicals at this point. Try to do this yearly. And most of these schools require this as a yearly basis. MDs, DOs, NPs, PAs can all participate in these physicals. Typically, this can be an office-based procedure, but again, I did this as a mass screening station-based at a school recently, and our practice does this at least twice during this fall season for the local high schools. We have the athletic trainers do the musculoskeletal exam. We have our medical assistants screen for the vitals, and they come back to see the providers for the review of the history, the heart, lungs, and the medical aspect of the exam. A lot of these physicals do have standardized forms. You can see on a lot of these websites, you can find forms that show, the physical itself. So if your clinic does not have a form, you can use one of these websites to find a form. And again, I think the history is the most important part. 75% of significant findings come from the history alone. So we shouldn't rush through this. We should have some specific questions that we're trying to ask about to evaluate these athletes and to see if they have a family history or the athlete themselves or a first-degree relative has a history of some kind of concern, and does this need further investigation. So again, don't rush through this history. Take the time with this. So again, what are we looking for? Cardiovascular symptoms or a family history of this. So, when I'm doing these physicals on the athlete, I ask the athlete, have you ever been participating in sports and felt like your heart was racing or skipping a beat? And then I ask the parent, Mom, Dad, is there any family history of heart problems at a young age? Heart attacks in the 40s, sudden, cardiac deaths? Not your grandparents' heart problems in their 70s, but a sudden cardiac risk factor in a first-degree relative. And this can be a large screening question, because if they say yes, and then you look at the athlete again and they say, yeah, occasionally with exertion I get some chest pain, then the answer is that athlete probably needs a pre-participation physical before proceeding, as to avoid the high-risk yield for this. Any pre-injuries, pre-surgeries, or incomplete rehabilitation. Have you, so again, I'll ask the athlete, have you ever had any sports-related injury that's caused you to miss time or practice? And any injury that they've had, I document in that extra section on the physical. Did they have appropriate evaluation? How long did the injury take to heal? Have they participated in sports since then? Do they have any residual side effects or issues with this? Is this something that we need to get a screening for? And again, this physical is not that screening. They'll have to make a separate appointment to come back to get that screening. Concussion history or any persistent symptoms. So concussions are common, especially in a lot of sports, not just in football or these high impact sports. Patients, athletes can get concussions from softball, getting hit by the pitch, soccer, other types of activities. How long did the concussion take to get better? Were you able to get evaluated for the concussion? Did you have nausea, vomiting, or persistent symptoms? Did it take 3-4 weeks for it to get better? That's a high concern of a pretty significant concussion, and they may have a history of a repeat concussion. Should they be participating in a sport where this can happen again? And I think that conversation, should be had with the athlete and the parents as to avoid long-term neurocognitive deficits. Asthma. So again, I asked the athlete, have you ever been participating in sports and felt like you couldn't catch your breath with rest? I think the with rest part is important. A lot of these athletes are deconditioned, especially in these fall sports, and so they have a difficult time catching their breath. And when they're out there participating in these sports, it's hard for them to catch their breath. But with rest, 3, 5, 10 minutes of rest, it improves. If they have, significant asthma, even with rest, the symptoms won't improve. They'll have those bronchial spasms and they'll require that albuterol inhaler or rescue inhaler. And then again, I go to the parents and ask the parents, do you have any family history of uncontrolled asthma, hospitalized asthma, severe asthma? So if they have a family history of one of their brothers, sisters, parents has significant asthma, is on multiple medications, that potentially predisposes them to that as well. And then we have to dig in a little bit more of, have they ever had a history of this? Are they seeing their pediatrician for it? Do they ever have any significant symptoms of this? Should they be carrying an albuterol inhaler around with them? If they do have one, a lot of kids are diagnosed with exercise-induced asthma. How often are they using this albuterol inhaler? And then again, heat-related illnesses. So sickle cell is obviously a big concern, especially in our hotter areas in the geographically, in the South. So do they have a history of heat-related illnesses? Occasionally they'll get muscle spasms, some type of nausea, vomiting, dehydration with these heat-related illnesses. So important to evaluate for this. Any medication, supplements, creatine could cause dehydration. Are they on high to low doses of creatine? Any menstrual history? Is it a heavy, menstruation where they could have some anemia, which could cause, predisposure to some type of risk factors? And then again, substance abuse or eating disorders are part of these typical questions. When we go through this cardiovascular exam, again, we want to ask, do they have an exertional chest pain or discomfort? Any unexplained syncope or near syncopal episodes? So I think the first screening question of, have you ever had a history of something like this, is important. And if it has, then go through this, go through this questionnaire here. Any prior restrictions, any cardiac evaluation, any premature death in their families or disabilities in their families. I had an athlete the other day that had a family history of long QT syndrome. Mom had it. The patient had it as well. Gets reviewed by the cardiologist every year. I cleared them from a medical standpoint, but I said they need cardiology clearance as well. So they have to go review with their cardiologist that they have a history of long QT syndrome. They were on a beta blocker. They had been stable on the beta blocker, but I'm not going to clear them for that because I don't have their history regarding that. I can clear them for the medical standpoint, but on the form, I can put must obtain cardiac clearance as well. And then again, the physical examination. So we'll talk about this a little bit more, but evaluate for heart murmurs. Do they have an S3 or S4? Can I do a Valsalva maneuver, and can that change the murmur from a supine to standing position or a squatting position where I'm increasing the flow across the heart with those activities? And then again, is their arm span longer than their height? Do they have these physical characteristics of concern for Marfan syndrome or EDH, Ehlers-Danlos, which is probably the more common one we see these days as these hypomobility or hypermobilities. And in some of these, if it's just the EDH that's hypermobile, it doesn't cause the vascular concerns. But if it's the traditional EDH, it can cause these vascular concerns of aortic aneurysms and other types of concerns. So we have to screen for this. During the examination, obviously, so we're going to get the vitals. We're going to do our vision check to make sure that they're not, worse than that 20/40 for single eye vision, checking both sides. We'll check their pupils to see if they are equal and reactive and if they have any nystagmus noted. Again, a cardiac history is probably one of the most important parts because, again, our biggest risk concern here is that sudden cardiac death. So evaluate for murmurs. And if you do hear like that S3, have them go into a standing and then a squatting position, have them Valsalva to see if that changes those heart sounds. Do they have pectus excavatum? I had one of my partners saw a patient that had pectus excavatum and was having surgery on it. And so again, should they be playing a sport where they can get hit in the chest? Quick abdominal exam, deep breaths, check their spleen, check their liver to see if they have any enlargement there. We'll get splenic enlargement with mononucleosis, that can happen in some young kids. And so we want to check to evaluate for that. A quick skin exam to see if they have any history of MRSA or contact dermatitis, eczema, psoriasis, whatever it may be. The genital exam, we don't always do in clinic. I think that's something that can be done by the pediatrician. Some physicals require this and some physicals don't require this. And then I think a neurocognitive, evaluation is important, especially if they have an underlying history of a concussion. So when we're doing that cardiac exam, what are we looking? So again, auscultate in a quiet room. Try to auscultate at multiple, positions. So, look throughout all of those positions on that anterior chest. See if the athlete has, a bradycardia. Now, a lot of, um, cross-country runners and a long-distance runner athletes will have some bradycardia, and that can be, very normal, in these patients. Check their pulses if you think there's a concern, regarding this cardiac exam. I think the third heart sound is probably the biggest one, right? So in low-frequency sound, heard in early the early diastolic heart sound. So just after that S2. So that's that Kentucky. So you hear that duh, but, duh, duh, but, duh, duh, but. So it's like that third little gallop that you heard. And in young athletes, that can be benign. It can be very normal. Now, again, anybody over the age of 40, it should not be, there should not be an S3. And so, we want to evaluate, are we hearing that S3, and is that a physiological murmur that's a normal in in a young athlete? Why are we hearing this? There's a generated rapid passive ventricular filling as the blood decelerates across the ventricle wall. And so that's what we're typically hearing. It's best heard in that left lateral decubitus position, and easily be missed with that early diaphragm evaluation. So, we want to check to see if they have any evidence of this. So when should we clear and when should we not? So again, cleared when the athlete is isolated, it's soft, and the athlete is asymptomatic with a normal apex of no murmur. When it comes with any dyspnea or exercise intolerance, or there's displaced apex, then we would want to consider a further evaluation, maybe that screening EKG. Quick, examination. So again, I'll do the ears, nose, throat, lungs, and heart examination initially, and then I'll just check for range of motion. So check for neck range of motion, look up, look down, look left, look right. Check for shoulder range of motion. Make sure they can abduct their arms against resistance, internal, external rotation, supination, pronation, and then spread the fingers. And then we go down to the knees. I'll bend and straighten the knee passively, and then I'll have them actively do it, checking to see for patella stabilization, any maltracking or instabilities they may have. I'll have them do range of motion of their hip. A lot of these athletes will have tightness in their hamstrings and or tightness in their hip range of motion that can predispose them to further injuries. So I'll check to see range of motion in their hip as well. I'll have them stand up, lean forward, check to see if there's any scoliosis, from evaluation of leaning forward. And then I'll have them go down to that kind of squatted position and back up a couple times, maybe even have them do that duck walk to see what their knees, ankles, and hip range of motion is. And as their screening patterns here, do they have tightness in this area? Is their squat technique pretty poor? And they may need to work on this to try to prevent injury prevention to the hip, knee, or ankle. So when would we stop the exam? When are these patients, hey, we need to get a further workup regarding this? Any exertional syncope. So anytime they have lightheadedness, passing out with any exertion, especially with any arrhythmias that you can, evaluate while you're listening to the heart, they need a further evaluation. They need to see their pediatrician, possibly get a cardiac workup, regarding this. Any exertional chest pain. So any reproducible chest pain, even if it is relieved by rest, they should get evaluated for this. Family history of sudden cardiac death, especially under the age of 50, especially in that first degree relative, they should have a full cardiac workup, regarding this. Murmur louder with Valsalva. So if they're bearing down and you're hearing that, a murmur get louder, that is a dynamic concern for an outflow obstruction, possible sudden or hypertrophic cardiomyopathy, and they should be evaluated for this. And it's easy to check this. If the patient's in a sitting down position, have them hold their breath and bear down, and you can check to see if there's a change in their heart sounds, and or if you're hearing that S3, have them go through this evaluation and see if there's a change. Any disproportionate dyspnea or fatigue. So even with conditioning levels, are they getting significantly fatigued more than they should be at their young age? It should be evaluated. Maybe they need lab tests to check to see if they have any electrolyte imbalances. Maybe they have a heavy menstruation and they're anemic and they need to be put on iron tablets. And then again, any concerns for morphinism or any type of Ehlers-Danlos or hypermobility that could cause vascular compromise, especially to this aortic root. Should we get EKGs or not? So that's this Italian test. They did, for the last 25 years, they've done pre-participation physicals, and with these physicals, they've done EKGs on these athletes to see if this is effective or not. And after 25 years, they had enough volume where they said it was effective, but it took quite a long time for this to happen. I think on a standalone, for most cases, the history in the exam is enough. We know that this may miss a lot of these cardiomyopathies. If they have a family history of this, again, I think they can get this evaluated. But most modern athlete-specific criteria or evaluations, we don't do these in. Obviously, higher-level athletes, college athletes, and professional athletes are definitely doing this. And again, in the U.S., we do not mandate these EKG screenings. I think these are evaluated on a case-by-case basis. So again, what are the major things to ask about when I'm asking these athletes? Any history of concussion? Again, any cardiac history? Again, any asthma history? Any history of sickle cell traits that could be exacerbation, by the heat or altitude? I live in Colorado, so the altitude can definitely affect that. Any previous history of heat-related illnesses? Any energy deficiency? So REDS is obviously out there, relative energy deficiency syndrome, and this can significantly affect a lot of things. Maybe they're not getting enough nutrition, enough hydration, and this can cause a lot of stress-related illnesses, any mental health disorders, and depression, anxiety, substance abuse. And again, these questions are definitely very tricky, especially with the parents in the rooms, because a lot of these athletes don't want to ask these questions with parents in the rooms. And then any use of supplementation that could cause any further issues. So again, when we're looking at these forms, typically there's a cleared without restrictions or reservations. There's a cleared pending further evaluation. So again, that patient I sent for further cardiac evaluation, that they had the history of long QT syndrome. There's a cleared for certain sports. So I have a previous history of concussions multiple times. I should not participate in contact-related sports, but I can participate in swimming or other sports like that. I had a patient that had a history of epilepsy. They're not cleared for, or seizures. They're not cleared for swimming, right? They shouldn't swim alone. And that change in temperature, jumping into a cold pool can possibly invoke a seizure. So they should not be cleared for that as well. And then not cleared at all. And this is rare, but oftentimes or sometimes can happen. Again, any history of carditis or any type of cardiac history, any history of uncontrolled hypertension. We have a lot of patients that come in that have high BMIs and they have hypertension on our evaluation. This should get a further workup, especially by their pediatrician, as they can predispose them to a lot of concerns. Any systemic illnesses, again, enlarged spleen or liver on the examination. If they have a history of undistended testicle or a single kidney, poorly controlled seizures. So again, no swimming, as we just talked about. I had that athlete with epilepsy. How long ago was your last seizure? When was your last seizure? So I had two athletes at this mass screening. One, her seizure hadn't been for 20 years and she was well controlled. The other one has a seizure 2 weeks before I saw her. She needs to get evaluation by, her neurologist. I can't clear her if she just had a seizure 2 weeks ago. Her previous seizure prior to that was, 5 years ago. So there could be some change that we shouldn't let her participate in sports regarding this. And then any consistent or unresolved concussion issues. Make sure you're communicating your decision clearly. Explain to the parents why this decision happened and what they need to do for a further workup. And you're just there to try to protect their athlete from some type of, adverse complication as a result of the physical. Share only what's necessary. So again, we don't have to add all the details to it, especially on this physical form, because this physical form is going to the school and they don't need to know this patient's in-depth history, from a HIPAA compliance satisfaction. Document your reasoning regarding everything. And then, if there's any injuries, make sure they're being evaluated or reassessed. 5 things to think about. The history does most of the lifting on these physicals. So the history is the most important part. Take the time to go through that history, ask these questions. Have 3 or 4 questions in your back pocket that you ask every time on every athlete regarding previous history of injuries, cardiac history, sickle cell history, and a history of asthma or any type of lung issues. Auscultate the athlete in that supine standing position or provocative positions every time. So I usually have them in a seated position. I'll have them stand and I'll have them Valsalva, while I'm auscultating them. Clearance is sports specific. What do you actually play? What are you trying to participate in? What sports are you participating in? Is your restrictions going to cause a significant effect to that sport? And again, restrictions beat disqualification. So we don't have to completely not clear them. We can clear them for certain sports, or we can clear them with an evaluation or a recommendation for further evaluation. Here's some of the websites, and some of the evaluation or, the different articles that I used with putting together this presentation. Again, I hope you enjoyed this presentation. Just a quick synopsis of those pre-participation physicals, kind of what are we looking for and what are we evaluating. Thank you for joining us and listening to the Ortho on the Go pod. I hope you enjoyed this episode. Should you want to communicate with us, you can email us at orthoonthegopod@gmail.com to communicate any thoughts or feedback regarding the episode or possible ideas for future episodes. Please follow us on both Instagram and Facebook at orthoonthegopod. And all of the videos for these episodes should be posted and or available on Apple Podcast, Spotify podcast, as well as our YouTube channel. Again, thank you again for joining us for this episode, and we'll see you in the next one.